Today's presenter is Melissa Reyes. Melissa is a stroke nurse.
First, I would like to say thank you and welcome. Thank you for spending your Saturday with us. That's very nice. Looks like we have a nice, intimate group here, so I welcome and encourage you to ask questions along the way. I don't mind if you interrupt if you have a question as we go along. I encourage that, please. So again, my name is Melissa Reyes. I'm part of the stroke team here at the hospital. So I wanted to start off with this quote: "A woman is more likely to die from a stroke than a man, yet prevention and treatment guidelines have always been targeted towards male patients until now." In fact, the very first research that was published was not until women targeted with women and stroke was not until 2014. So that's really quite recent. Prior to that, it was all men. So every research out there was only men inclusive. So it used to be thought that men were more at a higher risk for stroke than women. Since we suggest and we state that women are more likely to have strokes than men are. So how big of a problem is a stroke? There are approximately 795,000 strokes per year. The last data I have is from 2016. We don't have the 2017 yet. In 2016, there were 804,000 strokes reported. It is the 5th leading cause of death. This is actually better. When I did this talk in 2014, we were the 3rd leading cause of death. I think those statistics changed just 2 years ago. So that's better. That's showing us that with education, community education, and change of lifestyle, that we're improving from the 3rd leading cause of death to now the 5th. So every 45 seconds, someone suffers from a stroke. So this talk is an hour, approximately 1 hour. So during this talk alone, that's approximately 70 strokes that will happen just during this 1 hour, reported strokes. One person dies from a stroke every 4 minutes. And it is the #1 leading cause of disability in the United States today. Stroke is a leading cause of serious long-term disability. So remember how I said that we used to state that stroke was the 3rd leading cause of death, and now we are the 5th leading cause of death? So the stroke numbers have actually increased, but deaths have decreased. Does that make sense? So there's all that many more people that have survived, which is good, but there are also more people living with disability. So stroke is the biggest user of the healthcare dollar, approximately $33 billion per year. So in 2016, again, it was $33 billion reported just for stroke-related. Only 50 to 70% of stroke survivors regain functional independence. And 20% are institutionalized within 3 months after their initial stroke. 22% of men and 25% of women die within 1 year of their first stroke. So strokes, a person may survive the stroke, but then have all these other complications, which we will talk about further along in this talk. Approximately 55,000 more women than men have a stroke each year. That's huge. Stroke kills more than twice as many American women every year as breast cancer. So we always think with women with breast cancer, but actually stroke kills twice as many women. Women over the age of 30 who smoke and take high estrogen oral contraceptives have stroke risk 22 times higher than the average woman. African American women suffer a significantly higher number of strokes than Caucasian women, yet African American women were less likely to correctly identify what causes a stroke compared to Caucasian women. 1/2 of African American women will die of a stroke or heart disease. So this tells us there's a lot more room for education, community education. Did you know that only 27% of women could name more than 2 of the 6 primary stroke symptoms? And hopefully after this, you guys will know much more than that. Stroke is a leading cause of death for Hispanic women. However, Hispanic women were significantly less aware of stroke symptoms than Caucasian women. So what is a stroke? A stroke is a brain attack. So there's many facilities now that instead of saying stroke, they're using the terminology brain attack. I actually just saw an advertisement this past week, and they were using the terminology brain attack. And my husband turned to me and said, "What is that?" And I said, "Oh my gosh." So we had a long talk. So we use the terminology heart attack. It's the same thing. It's just where the clot ends up in the brain. So please think of stroke as a brain attack. Stroke happens in the brain rather than the heart. Stroke is an emergency, so please call 911 for emergent treatment. We have many patients that come through the emergency room and will say, "Oh, did they come by ambulance?" And the first thing we're told is, "No, I had my neighbor bring me," or "My wife brought me," or "My husband brought me." I really urge you to call 911. There are many things that the EMS team, so those paramedics, start for us and information that they receive for us and relate to us that is detrimental to your treatment once you get to the emergency room. So, and it's the brain. Things happen very quickly. You may seem like it's okay right now, and people say, "But I only live 3 blocks away." But in those 3 blocks, in that interim, many things could happen that your spouse or your neighbor would not be able to care for rather than the paramedics. So what exactly is a stroke? A stroke occurs when an artery of the brain becomes blocked or ruptured and disrupts the blood supply to a portion of the brain. Brain tissue can die or be injured, causing a change in neurological function. I know that's a big definition there. So there's 2 different types of strokes. Ischemic strokes, which is that clot in the brain not allowing for that surrounding tissue to perfuse our blood supply. Blood carries 2 vital things to your brain, oxygen and glucose. Your brain needs both of those things. So if there's a blockage there, that surrounding tissue, that surrounding area, will eventually die off. So 87% of strokes are ischemic strokes, the one that I quickly just described. 13% are hemorrhagic strokes, so what we know as bleeding strokes, so bleeding in the brain. So ischemic strokes, again, count for approximately 80%, so 87% of all strokes. An ischemic stroke occurs if an artery that supplies oxygen-rich blood to the brain becomes blocked. Brain cells in the area die from lack of oxygen and nutrients. So in this picture, but you see all this darkened area in the brain? That's all area that is no longer receiving blood. So it's no longer receiving the nutrients and oxygen that it needs to survive. So potentially all that darkened area of the brain is permanently damaged, or what we call necrotic tissue, so not salvageable anymore. Here's just another visual. I don't know if you can see from where you're sitting, but you see the clot that's in there not allowing blood flow anymore. This was what an ischemic stroke will look like on a CT scan. So all that darkened tissue is not salvageable, so it's dead brain, basically. This is a very large ischemic stroke. Yeah. The other type of stroke is a hemorrhagic stroke, what we described as a bleeding stroke. And it's when a blood vessel in the brain ruptures and blood leaks to or around the brain. The result is death of the brain tissue and brain damage. So the result, for the most part, is the same as ischemic, but just in a different manner. And presents very differently, which we'll talk about. So what are the causes of a hemorrhagic stroke or a bleeding stroke? Aneurysms, ballooning of a weakened region of the blood vessel, an AVM, or arteriovenous malformation, which is a cluster of abnormal blood vessels, and hypertensive bleeds. Sometimes we have aneurysms, we're born with aneurysms, so we develop them over time, but we don't know we have them until they become symptomatic, until they rupture. AVMs you are also born with. We don't know that a person will not know that they have an AVM until they become symptomatic. And then hypertensive bleeds, which are primary risk factor that we can control, are most controlled. So a weakened blood vessel here, you can see how the blood it ruptures in that blooded area, the brain, which will then in turn become deadened tissues again. So this is what it looks like over time. So all this darkened area is blood-filled, but that's also dead soft tissue now. So that area of the brain, your body will no longer be able to use.
So is it like
the hope is, and the potential is, that we control that bleed so it doesn't get any worse. So we control that bleed so it doesn't expand through blood pressure management, really tight blood pressure management. If it were in relation to a ruptured aneurysm, the treatment could be very different. We take you to cath lab, and we do what we call a clipping. So we clip at the site so that blood can no longer flow and release into the brain area. So sometimes as time goes on, your brain will reabsorb that blood. Many times it does. But we won't know what the complete effect is until it has already reabsorbed and we can see. Does that make sense? So sometimes the patient will come in and their symptomology-wise, their symptoms are really severe. But over time, they will get better and better. That's everybody's hope and goal. But we don't know, because we don't know we don't have like brain mapping where we know exactly what controls what. We know the area, surrounding area. So we know like what controls sight, what controls speech, the area. But we don't always know what the total effect will be until, time can tell. So transient ischemic attacks, or warning strokes. So that can happen before a major stroke. So many times we'll have patients come in and they'll tell us, and they come in with a very severe stroke. And they'll say, oh, well, yesterday I kind of felt this and I was unable to talk, but it only lasted like a half hour. So I just didn't come in. I thought I would be fine. Those are good warning strokes, and you should absolutely call 911. Or we'll have a family member call and say, I don't know if I should bring in my mom, but this is what's happening, but she's starting to seem a little bit better. Absolutely call 911. TIAs, to me, are almost just as severe, could potentially be just as severe as a stroke, a full stroke. So it occurs when blood flow through a brain artery is blocked or reduced for a short time. So maybe there's a clot there, but then it kind of dissolves on its own, so you gain perfusion again, blood supply to the area of the brain, and it goes away. But that's a real good indication, a warning sign that something's going on. So we need to find out what's going on so we know how to best treat it so that it doesn't happen again. Symptoms are temporary, but similar to those of a full-fledged stroke. And TIAs affect at least 240,000 people each year in the US alone. A person who has a TIA, or a transient ischemic attack, is 9.5 times more likely to have a stroke. That's huge. So when a patient comes in with TIA symptoms, even if they completely resolve in the emergency room, we absolutely encourage and want to admit the patient to be monitored at least for 24 hours, because we have to find out why that happened, why they had this little episode, why they had these symptoms, or we don't know how to treat it. So risk factors. Some risk factors are the same for both men and women: family history of stroke, high cholesterol, smoking, high blood pressure, diabetes, being overweight, and not exercising. So some of these are uncontrollable risk factors, right? You can't control your family history. But the rest, most of these, are very controllable risk factors. So risk factors that are unique to women are hormones. There's many studies going on right now. We don't necessarily have all the data that even women who are menopausal and on hormone therapy are at greater risk for stroke. Kind of the same reasoning and thought behind younger patients or younger women who are on birth control pills. So extra weight, migraines, so can increase a woman's stroke risk 2.5 times, and being pregnant. Strokes are 80% preventable if we just manage the lifestyle risk factors. 80%, that's huge. So remember earlier I said there were approximately 795,000 strokes a year. 80% of that 795,000 could have been prevented with control of risk factors. That would bring it down to like 100 and something thousand. That's a huge number. So some common signs and symptoms of a stroke: sudden numbness or weakness of the face, arm, or leg, especially on just one side of the body. Sudden confusion or trouble speaking or understanding. Sudden trouble seeing in one or both eyes. sudden trouble walking, dizziness, loss of balance or coordination, sudden severe headache with an unknown cause. So do you see how a lot of those symptoms are things that, especially as women, we kind of brush off like, oh, I just have a headache because, I'm stressed out, or gosh, we always have excuses and reasons. But really, truly, if you feel any of those symptoms, you should call 911. So for facial droop, to test facial droop weakness, have the patient or person, your loved one, yourself in the mirror, show their teeth or smile. So normal, both sides of your face will move equally, and abnormal would be if one side of the face does not move as well as the other. So asymmetric smile. And this is what that would look like. This person has left facial weakness. Do you all see that? Yeah. Sometimes it's not real obvious, it's not real predominant, so that's why we ask to show your teeth, because when you have to use the accessory muscles that way, it's a little bit more obvious. More defined. Arm drift. The patient closes their eyes and extends both arms straight out for 10 seconds. So you would have that person or your loved one who you're suspecting maybe possibly having a stroke raise both their arms. Ideally, you want to have them close their eyes. If one starts drifting down, that could be arm weakness. So normal, both arms will move the same, or both do not move at all. So they're still. Abnormal is unable to hold one arm up, or one arm slowly drifts downwards compared to the other. So this might be what it would look like. For speech, the patient is asked to repeat, "The sky is blue in Cincinnati." Really, we do not expect you to remember that line. Just ask them to say a sentence that normally they would be able to recite. And a normal reaction would be the patient says the correct words with no slurring of words, so easily understood. Abnormal would be the patient slurs words, says the wrong words, or is unable to speak at all. So stroke symptoms in women sometimes are more atypical than in men, actually lots of times. So just Thursday, my last shift here, we had a patient, a female, come in, and I was not called right away because the husband just said, oh, well, she just had a little kind of passing out experience where she just went to go to the bathroom and passed out for like 4 or 5 minutes, which is a long time, and kind of woke up on her own, just felt a little dizzy, so wanted to, she said she had blurred vision, so wanted to bring her in. Well, take her to CT, the ED doc here just calls me immediately, takes her to CT, and she has a quite large clot. Ended up sending her over to cath lab. Now she's doing beautifully, thank goodness. But if he would have waited thinking, oh, now she's kind of okay, we hear a lot of times, oh, just went for a nap, and then they woke up, and now they're completely, altered. But him thinking something was not right and calling immediately probably saved her life. This is not something we may typically see in a male patient or person, but in females, we do see these kind of passing out syncopal episodes often enough. So loss of consciousness or fading, which we don't always think about as a typical stroke symptoms, may be seen more frequently in women. They experience nausea, chest pain, heart palpitations, difficulty catching their breath, and sudden behavioral changes. So how to spot a stroke, again, when we're talking about symptoms. So we like to use the acronym FAST. So the F is for face drooping, arm, A is for arm weakness, S is for speech difficulty, and T is for time. Time is everything when you suspect a stroke. So FAST is just an easy way to remember what to look for quickly. So what do you do if you suspect a stroke? Please call 911. Time lost is brain loss. So for every second that a patient is lacking blood flow to their brain, they're losing over 1 billion neurons. So what can be done for an acute stroke? So for the ischemic stroke or the clotting stroke, these patients may be appropriate for what you might know as the clot-busting drug, TPA, tissue plasminogen activator. It requires rapid coordinated response. IV TPA can only be given within the first 3 hours of symptom onset. I almost changed this number from 3 hours to 4.5 hours because really we're starting to use 4.5 hours. It just hasn't been necessarily approved by the FDA yet, but it's all going through. But really, we look at the patient themselves, and it becomes more patient dependent. There's a physician up at UCSF who will give TPA up to 24 hours and have shown benefit of that. So we are really pushing along and expanding our window and expanding our criteria and decreasing the exclusion criteria. So the things that used to be said, oh, don't give TPA if da-da-da-da, because we're finding the benefits of still giving it are much greater than the risk. Does that make sense? So this number says 3 hours, but if I have a patient come in and they meet this criteria, I guess, I would definitely do it up to 4.5 hours. So the expected response time from when a patient comes to our emergency room to receiving the TPA is 60 minutes. I could tell you how amazing our hospital is, that we average 20-25 minutes, which is super fast. And like I said before, every second counts, right? So the earlier you're receiving this medication, the quicker and the sooner and the better the outcome, hopefully. So this was just a study that was done, and there's many studies even after this. This was done in 2000, but it was a huge study. But there's been many studies done after this that do suggest and hold true to the quicker you're receiving this tissue plasminogen, the better the results in the end, the better the outcome. So truly, if you are suspecting any type of stroke-like symptoms, call 911. What that does for us is EMS, like what we call ring down, calls our ER and says, this is what I have coming in, I have a possible stroke. Lets us know a little bit of history of what they could obtain. When you come through our emergency room, a stroke nurse like myself, the emergency room physician, the labs, the pharmacist, the CT tech, we're all hyper aware, and we are right there. We are there before you're there. So when you get there, we are ready to go. The EMTs or paramedics, they have the IV sites ready that we need. They have the EKG for us already, so we see what kind of cardiac rhythm you have. They have all your initial vital signs. They let us know what the symptoms are before you even arrive. So it really gives us a good indication on what way we're gonna take before you're even there. So it saves so much time, and time is everything. Time is brain. So please call 911, that's my whole point. So more treatments for ischemic stroke. So if you were unable to have that TPA, like say symptoms began the day before, which we see quite often, or 8 hours out, or it wasn't indicated, there's another reason that it wasn't indicated for you to receive the TPA, there's other things we could do, like anticoagulation. So warfarin, aspirin, sometimes we'll start you on heparin here, and then you transfer over to Coumadin, which is also warfarin. We could have a carotid endarterectomy. So if there's lots of stenosis, they could go and try to fix that. Angioplasty or stents. So for hemorrhagic strokes, it's very different. So it depends on the location and severity of the bleed. The patient may be a candidate for a craniotomy. Neurosurgeons are on call 24 hours a day, 7 days a week to address this need. So they will literally remove a portion of the brain to allow for brain swelling. So what happens is when you have a brain bleed, that blood needs to go somewhere. So you have your brain, right, and your skull is surrounding your brain. So if there's blood or something filling in this area, the brain has to go somewhere. So it will start swelling, right, allowing for room for that blood. And two things could happen. One, it's going against your skull, which is causing damage. Or two, it goes downwards into your brainstem and could potentially cause what we call herniation or hernia, which could cause death. So to remove some portion of that brain will allow room for swelling, causing less damage into cerebral damage, so less brain damage. So then again, we're talking about the hemorrhagic bleed. So endovascular procedures like coiling. So I know I talked about clipping if there was an aneurysm causing this brain bleed, and they could clip at the bulb of the aneurysm, not allowing for blood flow, but there's also coiling, and they use this titanium material, and they go up and they fill it up so that there's no room for blood to get into this aneurysmal bulb anymore, right? And so it does not allow for blood to flow through into the brain tissue. So strokes are preventable if the risk factors are controlled. Remember we talked about approximately 80% of strokes could have been prevented if risk factors are controlled. So these are some of our preventable risk factors: hypertension, high cholesterol, smoking, atrial fibrillation, and heavy alcohol use. So how many strokes can be prevented? I was trying to look for an even more recent one. This is in 2014, which is still pretty recent. So this is on accounting for 699,000 strokes. So hypertension, 360,000 strokes could have been prevented if hypertension were controlled. So it was thought to be that 360,000 of those strokes were related to hypertension. Cholesterol, 146,000. Smoking, 90,000. Atrial fibrillation, 69,000. And heavy alcohol use, 34,000. So if all of these risk factors were controlled, all of these numbers could have possibly have been prevented. Those are all that many people or patients that would not have had a stroke. So prevention, the most important goal: see your doctor regularly. I cannot tell you how many times we have patients coming through the ER and I ask, when was the last time, or who's your primary care? They say, oh, I haven't seen a doctor in 20, 30 years. There was no need to. And I'm like, oh my gosh. So there's a need to see your doctor. That's why they're there. Take your high blood pressure medications as ordered. I will also tell you that I will routinely have, at least once a shift, patients say to me, well, I haven't taken my blood pressure medication, or I haven't taken my cholesterol medication for 3 months now, or I stopped that last month because last time I went to the doctor, my blood pressure was fine, so I don't need to take it anymore. Really, your blood pressure is probably fine and your cholesterol looks good because of those medications, so please do not take it unless your doctor states that it's okay or suggests that it's okay to stop taking. Take your own blood pressure at home and keep a record of it. You know, even at, like, if you don't have a blood pressure cuff, even at Walgreens or Rite Aid, they have all those machines now. If you feel like your blood pressure might be high, or you're just curious what it is, please go and have it taken. Keep your weight down, exercise regularly, eat right, and stop smoking. So for me and to me, diet's a huge deal. Diet helps control, you know, if you're on a good diet, right? Your diabetes, it will help control your cholesterol levels. There's some even simple things. I brought this thing of sugar. Each one of these sugar packets is 1 gram, is equivalent to 1 gram. My husband is a drug and gang task force, police officer. And so he always uses an example as 1 gram as 1 sugar packet. 1 can of Coke, 1 can of soda is 39 grams of sugar in 1 can of regular Coke. That means this whole bag, this is 39 packets. All of this sugar is in 1 can of Coke, 39 of these. That's crazy. So even if you drink soda, even cutting that out alone would be fantastic, right? So I just want to bring that as a little visual. People don't realize what you've learned about stroke. So we've discussed how women have unique set of symptoms and risk factors. It's a major killer and disabler. 80% of strokes are preventable with lifestyle risk factors, management of lifestyle risk factors. It can be detected early. If you have any questions or thoughts, or I kind of feel a little bit funny, I don't know what's going on, call your doctor. At the minimum, call your physician. Because then if they feel like you should call 911, if you really truly think that something's going on, just call 911. It is treatable, time is critical, and it is an emergency, so please call 911. If your loved one or neighbor or whoever is bringing you and you get into traffic, you're stuck. At least with ambulances, they could put lights and sirens and they could go on the median and they could get you where they need to go. They have resources right in their rig, in their truck, to help stabilize you until you get to us. They give us so much information. I just stress this so much because I see this all the time. And it could be life-saving. So to learn more about stroke, this is a stroke hotline, or you could go onto the strokeassociation.org. That's a fantastic website, and it's really user-friendly. I don't know if you all received the catalog, I think it's the health and wellness catalog from the hospital, but we do routine stroke education talks also. I do them. We're doing one again this Tuesday at the Nakamura Clinic. It's the first series, it's a 2-part, it's the first part, so I invite you all to come too. So it's a little bit different than this. And then any questions?
If you can wait for the microphone.
I had a question. If you've had one stroke, what's the probability that you'll have a second one?
Perfect, 3 times as likely. So you're 3 times as likely to have a secondary stroke. So of that 795,000 strokes on average that I stated earlier, most of those, I think it says 77% of those are second or third strokes. So that's a very good question. We talk about that actually on Tuesday. So good question.
We have a question here.
Are there age factors?
So, it's another good question. So when we first started this program 12, 13 years ago, I think strokes were considered an older man's disease, right? So I would even, and sometimes I still do now, will have even an emergency room physician say to me, oh, it's a young female in their 30s, don't worry about Melissa, but I just want your blessing, just kind of come and see this patient. I really don't think it's a stroke. And I'm always like, oh my God, they don't want to say that to me anymore because they know I go a little bit crazy. But I go in there, and more times than none, we are finding so many, even younger women, younger men with strokes. I think that's in the past, so many patients, it wasn't thought to be a younger person's disease. So before we would have said yes in older patients, right, like 70s and older. But I could tell you right now, I have 12 stroke patients on this list here. So this is the patients I have to see daily. There's 12 of them in-house. Of the 12, 9 of them are 50 and younger. So good question, but I'm gonna say that I don't know truly if there's a certain age group anymore that we kind of concentrate on like we would have in the past, right? The older patient population. Now I say everyone because it's true.
Question over here.
Hello. So my mother had what they called a mini stroke last year. What exactly is a mini stroke? Is that just a partial blockage? Or?
No, so I hate that term. I will say that. Yeah. So mini stroke is what people sometimes refer to as a TIA or transient ischemic attack. So you have these stroke-like symptoms, yes, and they go away. I don't like that term because if you have a stroke, you have a stroke. There's no such thing as a mini stroke. Thank you.